Our first speaker requires very little introduction to those who have been involved in the ME community for any length of time. He is known to us as a dedicated clinician, being on the front line in Incline Village in 1984, when a serious outbreak of ME brought the disease to the forefront in the United States. He has persevered and over the years treated hundreds, if not thousands, of patients with ME and built a 1,000-plus patient-strong biobank. That biobank is bearing fruit in exciting new research findings, which we will hear about today. He is an internist by training and an internationally recognized expert in ME. His experience as both a clinician and a research collaborator provides a unique perspective on ME/CFS for developing translational science. We are very grateful he has taken time from his incredibly busy schedule to be here today. Please welcome Dr. Daniel Peterson.
It's a pleasure to be here, and particularly to see some old friends. Ian and I met many, many years ago, so it's nice to be invited up here. And I'm really impressed by things that are going on in Canada, but I'm really going to talk about the cross-border stuff today, particularly with respect to, I was tasked with discussing the recent events. So everything you're going to hear about today is from January 2015 forward. So it was sort of fun for me to be able to prepare that. And I also enjoyed the opportunity to travel some and see another part of the country, although I don't live in too shabby of a place myself, as you can see. So I wanted to start with the Pathways to Prevention, the P2P program. And a lot of people don't understand the P2P program because it did not come from the bottom up. It came from the top down. It was ordered to be achieved, and it had very specific goals. And what was most controversial is they did not consult any physicians who had any knowledge of chronic fatigue or ME. It was to have been completely objective, based on evidence-based medicine. It's a relatively new program in the United States, and it's I think it's had 3 or 4 diseases that have been subject to this process. And the goal is to figure out ways to prevent chronic disease, hence the Pathways to Prevention moniker. And chronic fatigue, as I said, ME, was selected because it was poorly studied and needs direction. So controversy aside, I'll proceed here. So the goals were to identify research gaps in ME/CFS and to establish methodology and errors or perhaps weaknesses of the current diagnostic and research trials, to suggest areas of research, and then providing ideas for future research and treatment strategy. So it was a pretty big assignment that this committee was given. And so there were gaps identified that were very significant, and this has been somewhat controversial, but I'll go over them one by one. The first one, and the one that we still struggle with after all these years, is a definition that everybody agrees with that can be used for research and clinical trials. And I'm an old pro at this because I was part of the 1988 Fukuda criteria and the Holmes criteria and the 2003 consensus, and we're still, after 30 years, fighting this basic issue of a definition. Well, the solution that was proposed was to have stakeholders, meaning patients, physicians, researchers, to agree on a consensus of the definition. The second point was that this should really be national and indeed international in terms of a research network. Thirdly, and this I think is important, they stressed that there should be commonalities and comorbidities with different disorders. For example, what are the similarities with Gulf War syndrome? What are the similarities with Lyme disease, fibromyalgia, and what are the differences? And then lastly, the goal was to propose translational medicine, bench to bedside, where the researchers collaborated with the clinicians. And this has been a goal of NIH for a long, long time, but I'll tell you, it's much harder to execute it than it is to say do it. And so that's a goal that still eludes us, I think. The specific recommendations that they made are interesting, and I won't spend a lot of time going over all of this with you, but I want you to learn the terminology because it really demonstrates how modern technology and modern research is impacting chronic disease, regardless of what the chronic disease is. And I've bolded these terms because most of you are familiar with them. I won't spend time going over each one of them, but I'd be happy to if you had a specific question. But GWAS, or genetic studies, is screening for a genetic predisposition. And that's saying, do you sufferers of chronic fatigue or ME have a reason genetically that you develop this disease? Of course, they recommended looking for biomarkers. Wouldn't we love that? I would be retired, Ian would be retired, everybody would be retired if we had a reliable biomarker that had been validated. They recommended, of course, cutting-edge technologies such as throughput sequencing. And an example of that is, you're all probably familiar because this is a hot topic, and that is looking at the gut biome. And in order to look at the gut biome, it requires a very sophisticated technology because of all the different bacteria, viruses, and everything that's in our gut, as well as all the stuff that isn't part of us but is passed through from foods, what the germs that are on lettuce, et cetera, et cetera. And there are many studies going on in this area right now, so it's something you really should pay attention to and be aware of. One of their tasks that they avoided was how to identify patients that are at high risk for chronic fatigue syndrome. And that's going on in an infectious disease model, like who's at high risk for developing HIV or multiple sclerosis or something like that. They again suggested that we use data mining. It's a technique, it's called big data now, and that's sort of coming to an issue without a predisposition that says what can we find just looking at the data. Of course, you have to amass huge amounts of data in order to do that. Many of you have been probably asked to enter into a data mining study, and I urge you to participate. They did identify that most of the good research that's been done to date has been in cytokines, inflammation, NK cell dysfunction, and they recommended continuing following up along those lines. They made an interesting request that twin studies be done, particularly in discordant twins, where one is sick with ME, CFS, and one is not, with gene expression. That's been done before looking at other variables, but not with gene expression. And then investigate the effects of complementary and alternative medical treatments. And that's because a great number of patients spend a great deal of money on alternative remedies that have never been proven to be beneficial. And lastly, they suggest national biobank rather than even regional biobank that everybody could access both for specimens as well as for information and data. So the second gap that they identified was lack of federal spending. Now, probably that's a problem in Canada as well, I would guess. And it was advocated that at least bring it up to the amount of money spent on other diseases. And that seems to be really a simple request, but very difficult to achieve. Thirdly, and many physicians are sensitive to this, Ian and I were talking about this, is they bashed most of the research that's been done in chronic fatigue ME as being poor quality, low numbers, underfunded, and that better studies need to be done. And I entirely agree with that. One of the problems designing better studies is we don't have good outcome measures. And Staci, I think, will be talking something about outcome measures to follow. And some of the problems with studies are, we need online tracking tools, how to study the immobile patients. This is a huge issue. I'm on a CDC committee. How do you reach the people that are home? We don't even know how many that are homebound and in bedridden. They can't come in for diagnostic studies. They can't come in for follow-up studies. They can't come in for genetic testing. So it's a huge problem. And the P2P said we must address this. Some of the socialized countries have actually done better at this, Australia, et cetera, because they have logs of all their patients and they can actually go after them if they haven't been seen for 5 years or something like that. That's a great deal of difficulty for us to accommodate that request that the sickest and most immobile patients also be studied. Community-based research means that this disease may not be the same in Vancouver as it is in Incline, as it is in Australia, as it is in the UK. So they did stress that we should be looking at community-based. Maybe you have different factors here, different toxicities, different viruses that could come to play. The issue of psychiatric comorbidity raises its ugly head year after year after year after year, and is always an issue that should be addressed in any study that one does. And then long-term longitudinal studies are in place on part of a 5-year CDC study. We've done a 10-year follow-up study looking at the incidence of cancer in patients with chronic fatigue at 10 years and at 20 years. And we've interestingly found that the risk is 4 times the general population for development of neoplastic disorders in 20 years. And then lack of provider education. And we all know there's still physicians who don't recognize chronic fatigue ME, that know nothing about it. We know that there's nurse practitioners that don't know anything about it. We know that there are medical schools, recently only 7% of the medical schools in the United States even had a minimal curriculum for chronic fatigue. And they suggested that national resources could be used to disseminate information. And I think that remains to be determined exactly how to do that. They did suggest more clinical trials, and they suggested that the federal government could be helpful in creating websites for educational materials, to actually operating clinical trials, which they can do, but they rarely do, and explore fast tracking for drugs and therapies. And the reason for that is because there's no available therapy. There's no FDA-approved drug for chronic fatigue ME. And until there's one, the drug companies won't be interested. But Big Pharma funds research. So it becomes an evil cycle. If you had one drug licensed, you'd see Big Pharma want to be interested in this disease. And then establish new pathways of development. Perhaps standard pathways of drug licensing aren't appropriate, since the average drug costs about $300 million to bring to market now. That would be difficult to convince a company of the utility of. And then again, long-term longitudinal studies to see what really happens to people over time. Many of you have probably been sick for many years, but you probably haven't been systematically studied for development of comorbidity, for example. And then, of course, they recommended patient participation and continuation of multiple modality therapies. And that point means that while nothing's been proven to work, we clinicians should continue trying to treat you. And then, which you all probably should applaud, they advise doing away with the Oxford definition. Okay, so I wanted to give you some response in the United States. I haven't heard much about the response in other countries, in Australia or the UK or here for that matter, but Solve-ME says that this P2P process was not appropriate for ME-CFS. And the reason for that is that it required evidence-based medicine. And there simply is very little evidence-based material in CFS. They did agree that the studies have lacked rigor and that study design needs to be improved. And they clearly said that ME-CFS has been underfunded. The IACFS made an official statement that there was inadequate funding. You're starting to see a pattern here. And that even if you make recommendations at the federal level, they don't happen. Thirdly, that it really would require an institutional change within the NIH to change the emphasis from the Department of Women's Health to an institute that has more influence and better funding. The next point I found very interesting, that on average it takes 17 years for a new diagnosis to catch on in the medical world. So that's for everybody to accept it, utilize it, and institute appropriately. And then, of course, this was not an international effort. This was a U.S. effort. And there's nothing to suggest that the disease is unique just to the United States. So I'll move along now to the Institute of Medicine, which is charged with making statements on public health policy. And it's an independent branch of the Science Institute, and it's known for being independent and fair and objective with respect to standards of care, diagnosis, etc. And probably a lot of you are familiar with their efforts at describing Gulf War syndrome, which has been controversial, as has their definitions for chronic fatigue ME. So this particular study was commissioned in response to CIFSAC, and with the point of, again, using stakeholders, ME experts, patients, advocates, to reach a consensus basically on case definition. And they were charged with using the Canadian 2003 definition as a base, but to address any inefficiencies or inaccuracies of that particular approach. So they were charged with developing an evidence-based diagnostic criteria that met everybody's needs, patients, physicians, researchers, recommend new terminology, and then develop an outreach strategy and plan for updating a new criteria. And you're probably familiar with this controversy as well, because there were very few physicians with experience in chronic fatigue syndrome on that particular committee. They did, however, submit their recommendations for outside review, and whether or not people's outside comments were included is not clear. So, as you all know, undoubtedly, they did propose new diagnostic criteria for ME/CFS. And the diagnosis requires substantial reduction or impairment of ability to engage in pre-illness levels of occupation. You're all familiar with this because that was a carryover from all previous definitions. They clarified it some and they made it operational. They did outline techniques for physicians to classify people the same way, and it's a very useful document for particularly primary care physicians, as it tells them specifically what questions to ask, etc., in all of these areas. Secondly, and I think everybody in the world probably agrees with this, they made post-exertional malaise a requirement for the diagnosis rather than an option. And the reason for that is it seems to be somewhat unique to this group of chronic illnesses, because exertion in general makes most chronic illnesses more tolerable, although it doesn't change the outcome. In CFS-ME, it clearly exercise inappropriately makes people worse. And then unrefreshing sleep. Now, unrefreshing sleep sounds very vague, and it is, but if you read the operational definition, the physician's guide, it outlines what the definition of unrefreshing sleep is. And then at least one of the two following manifestations, cognitive impairment and or orthostatic intolerance. And again, cognitive impairment is very broad. They made some suggestions as how you might assess cognitive impairment and orthostatic intolerance. So what people felt was the biggest strength of the IOM was that they made this blanket statement that I think the whole world picked up on, and that is ME/CFS is a serious chronic multi-system disease that frequently and dramatically limits the activities of affected patients. And that really has had an impact of people, of the press, New York Times, et cetera, saying, oh, I guess this wasn't all garbage all along, it was really something, because that statement came from the IOM. And then, again, they proposed after that their criteria. So they made 4 key recommendations, and I want to go over those quickly because they're somewhat important. The first is that physicians should diagnose ME/CFS proactively. It shouldn't be something they come up with because they couldn't find anything else. And that's a very critical difference. And that it be signed a new code in the ICD-10, which we're required to use. All American physicians and medical institutions have to use this new coding system in October of this year. So that was a very good and helpful recommendation. They did recommend a standardized toolkit for screening and diagnosing, and that toolkit is useful. It has specific questions that physicians can ask in order to aid them in the diagnosis, and that the criteria that they set should be reevaluated in 5 years, because they probably should be evolving and changing and as we have more experience with it. And then they suggested replacing the name ME/CFS with systemic exertion intolerance disease. Now, I want to try a little exercise with all of you patients in here. And just bear with me. It's really for my education, but you might find it fun as well. So I want to go over the new diagnostic criteria and the new algorithm and see how well it works for this audience. So it'll be quick. It'll be easy. So let's start with this. Everybody raise their hand that has fatigue. Keep it up. Keep it up if you can. Okay. Now, put down your hand if it doesn't disable you. If you have fatigue but it doesn't disable you, put down, okay? All right. Persisting for more than 6 months. Keep those hands up. Put it down if it doesn't apply to you, okay? Post-exertional malaise. That's what I'm trying to do. Post-exertional malaise. Get worse with exercise. If that's not you, put your hand down. Okay? All right. Cognitive impairment. If you don't have cognitive impairment, put your hand down. Okay. Orthostatic intolerance. If you don't have orthostatic intolerance, put your hand down. Dizziness with standing, rapid heart rate, things like that. All these hands are still up here. Okay, so that's fine. You can put them. So the algorithm essentially identifies everybody, which is the point, and that's one reason why they wanted it. On the other hand, maybe half of you have some other disease, and that's sort of the problem. So, but it is an algorithm. It's easy to understand. It takes 5 minutes for a primary care physician to go through this, which is potentially helpful, and they can make a definitive diagnosis. Now let me throw some controversy in here, okay? And this is not my commentary, but this is from published literature and editorials, etc., about the IOM process and the new definition and the new name. We all know that chronic fatigue syndrome has done a disservice to many, many patients. Many people think SEID is no better. Systemic exertion intolerance disease is felt to capture more the nature of the disorder, but it's even hard to say. And all of the literature needs to be rewritten, all the grants need to be rewritten if we're going to adopt these criteria. And remember, these are just recommendations. These have not been adopted, although in general, the recommendations of the IOM are followed. They did produce a very thorough, evidence-based, very prolonged report. That book I showed you is 300 pages long. And it's actually very, very thorough. If any of you want to know information about all the studies that were reviewed, et cetera, go to that source. It's really excellent. They defend themselves that they sorted through 100 names that were suggested in order to come up with SEID. They did recommend that this be reevaluated in 5 years. Many of the other definitions they just go on forever. You know, they're cast in stone. And they defend themselves in that rather than to presume a cause, they wanted to focus on the main symptom of post-exertional malaise. And then, of course, diagnostic criteria name will evolve over time, but how many times do you want to make changes in the name and criteria for a disease? And here are some issues that I think should be contemplated. First is, IOM may not gain significant support from the International Research Committee because it wasn't done internationally. And furthermore, can it be used for research? Is it rigorous enough to be used for research? And that's a huge question. David Tuller of the New York Times speculated that patients would not accept the new name. So we're going to vote again. Here we go. Raise your hand if you love the new name, endorse it, and think it's going to make a big progress. Raise your hand if you have the same doubts that Mr. Taller brought up. Okay, thank you for that vote. Invest in ME, I think, made a very poignant statement that I want to pause and think about. Will this report promote a more prompt diagnosis of patients with this complex, multi-system and devastating disorder? Will it enhance public understanding? And will it provide a firm foundation for future diagnosis and treatment? And I think those are questions that really require careful consideration, validation, etc. With respect to the name change, I'm afraid that it might just be accomplishing this, identifying another group of patients that is somewhat artificial and overlapping with other syndromes. But again, this needs to be validated. It would be interesting to apply this, and you and I were talking earlier, with Lyme disease, Gulf War, etc. Because I suspect that the patients with those diagnoses will also meet the criteria for SEID. So the overall impression of the IOM, it's a very respected and influential committee. They made a very strong statement about the severity of the disease, and that's good. It includes an extensive literature review that's really useful to patients and to physicians. It's very current. It was done electronically. They searched for keywords, and it's a very good report. They propose new diagnostic criteria that I say must be studied, validated, and compared to previous diagnostic criteria, and that's going on right now. Many sites are comparing the different criteria. There were very few IOM members from outside the U.S., so it's really unknown whether this will ever be accepted as an international diagnosis criteria or not. Comorbidities are allowed, and I just showed why that can be very confounding and confusing. And rather than have a homogeneous group, SEID may again be creating a heterogeneous group, but a different heterogeneous group. And there were a number of editorials that made these same points. It appeared in WebMD, Nature, Medscape, JAMA, Science, and Annals of Internal Medicine. So the IOM report got a lot of international attention. So let's talk about basic research, because without addressing this, I think the future is very bleak. In 15 years, the NIH has spent $191 million on CFS. They've spent $400 million on fibromyalgia, and they've spent $4 billion on multiple sclerosis, a much rarer disease that we know the cause and we know the treatment. So with respect to literature that's so widely criticized in this field, of peer-reviewed literature, they reviewed 5,400 publications in ME/CFS, which is actually quite a lot, but it's probably not enough given the significance of the disease. In fibromyalgia, there's 8,000 peer-reviewed pieces of literature, and in multiple sclerosis, there's 55,000. So I wanted to go over some of the things that the NIH is supporting so you can see where they've determined worthy of funding, albeit in a very limited way. And some of these are things you'll see a pattern here with respect to what should be studied and what is studied. And one of them is exertional exhaustion in CFS. Can we identify the specific phenotype that's prone to exertional exhaustion? MicroRNA in the spinal fluid, there's a new grant for that. Gene expression to determine CFS from controls. That would be very useful because it's a pretty easy technique to do now. Computational biology, I mentioned that before. That's taking masses of data and correlated it with clinical symptoms, etc., to see if there's patterns that arise. Gender differences, they finally funded a big study to look at gender differences because CFS-ME is more common in females, although not as much as once was thought. The hot topic, as I mentioned, microbiomes and inflammation in chronic fatigue syndrome is a study that's ongoing now. Cellular metabolism of lymphocytes is a study going on. If we know that the NK cell function is low, for example, why is it low? Why are those cells not working? So that's a very useful basic science study. There's a lot of interest now in magnetic resonance spectroscopy, which is a technique that's been around for a while but had not been applied to look at chronic fatigue syndrome. There's a study I'm involved in to look at genetic predisposition for NK cell dysfunction. Prospective study of chronic fatigue following infectious mono. These can be very, very interesting studies because they can tell you who's at risk for developing chronic fatigue and also how they do. And the pilot studies have been done in Australia with respect to that. This study is in Chicago. The role of Toll-9 receptors in infection gets to why viruses might have a role in chronic fatigue syndrome, ME. Post-exertional ion channel gene expression is something that Staci's very interested in, and you have some interest here in British Columbia with respect to changes in gene expression after exertion. Development of chronic fatigue syndrome and non-Hodgkin's lymphoma. That's a longitudinal study that I'm involved in because I've been seeing patients for such a long time. And as I mentioned to you, there is an increased risk for brain tumors and non-Hodgkin's lymphoma in patients with chronic fatigue syndrome. Subdividing subsets of patients in chronic fatigue, that's very, very useful because we know it isn't one disease. It's many, many different faces of the same thing. And that particular study is looking at spinal fluid blood flow, lactate with spectroscopy. Novel biomarkers, everybody around the globe is looking at that. This particular study at Nova Southwestern is with RNA sequencing. Gene sequencing after exertion is being looked at. Oxidative stress biomarkers. These are all funded projects that are in progress as we speak. There's one drug trial with NAC for oxidative stress, and we'll look forward to that. That's following one particular model. We're looking at brain mast cells in chronic fatigue syndrome. Mast cells are felt to have a critical role in a number of inflammatory diseases, and it may play a role in your illness. And then there's a very interesting study on how a virus impacts your wellness and your sickness and anxiety behavior. And we have knockout mice, finally, that can develop chronic fatigue syndrome. So it's much, much easier to do research in a mouse model. It's faster. Mice aren't exactly identical to people, but we bear quite a bit of similarities. So that's a pretty big breakthrough. And then there's interesting studies of cytokine profiles and daily variation. That's a summary of what NIH has funded over the past couple of years, and those are ongoing studies right now. With respect to therapeutic trials, it's not quite so good. Poly-I, poly-C12U amphogen is still on open label, but is still not approved in the U.S. There are several studies studying rituximab, and we're waiting to find out who are the right candidates for that therapy and how long should they be treated and with which doses, etc. Something I'm very, very interested in is the use of cytokine inhibition, because there's a lot of evidence that many, many of the symptoms that you suffer from are cytokine mediated. Xyrem in patients with chronic fatigue syndrome for sleep is being studied. Partner patient stress management is being studied. And then there is a study underway with respect to the effectiveness of acupuncture. So I wanted to share with you 4 recently published studies to show you that things are happening and are reaching the literature. And these are just from the this year alone. And in no particular order of importance, Stanford published this functional MRI study that showed white matter loss in the right arcuate fasciculus reproducibly and not seen in other diseases. And after the publication of this study, there was a huge amount of interest. This one got brought up in Wall Street Journal and New York Times, etc., again under the auspices of this is a real disease. There's something wrong with the brains. And, and so that was very useful. And here's their slide demonstrating these portions of the brain that are not functioning properly and can be detected reproducibly. The Center for Infection and Immunity found distinct plasma immune signatures in ME and present early in the course of illness and not later in the course of illness, and this was a real breakthrough. I presented the patients for this study, and while it was my suspicion, I'd never been able to prove this. So early on in the disease, according to the cytokines, you have a marked inflammatory response. Later in the disease, you have an exhausted immune system. And we really didn't anticipate this, but they used a 3-year cutoff, and it was very reproducible. So it's very important for studies to pay attention. Are you early in the course of the disease or are you late in the course of the disease? Because it may be more beneficial to use cytokine blockers early in the disease before you have the immune exhaustion. The Center for Infection and Immunity at Columbia with Ian Lipkin also studied cytokines in the spinal fluid because there's differences in spinal fluid dynamics versus peripheral blood. And they again found evidence of immune activation in the spinal fluid, which fits a lot of the symptoms that you have in terms of cognitive dysfunction. And the red represents cytokines that are downregulated, and the green indicates cytokines that are upregulated, and the control group was multiple sclerosis. And what was interesting about this is they were able to very clearly identify, look at the p-values, they're ridiculously low, clearly identify patients with MS from controls from patients with chronic fatigue syndrome. So we've now launched into the phase 2 of that particular study, which is looking at the proteomics and gene expression in the spinal fluid, which may be useful. And then the pilot study that sort of got this all going was a collaborative study with Griffith University, and which also demonstrated disturbance of the cytokine levels in the spinal fluid. And what that study showed was a decrease in IL-10, and IL-10 is a cytokine that shuts off your immune system. So with a defect of IL-10, you'll have an activated immune system. And all these cytokines, of course, are subject to regulation and drug intervention and other modalities. So University of British Columbia, I just found this publication like from May the 20th, so hot off the press right here at home, and probably some of you were part of this, demonstrating the use of sub-maximal exercise testing and spectroscopy to see if you can identify characteristics and interventions, perhaps, in diagnostics. Microbiome is being done at 5 sites. This is hot in this field right now. It's hot in autism and other disorders as well. You probably know about that. And then the long-range study, the CDC is doing their 5-year follow-up, and there's other studies that are trying to do longer follow-up as well. So here's some future studies that have been funded but are not operational yet. And the one is an arthroboard study in 5 sites. And the special cases looks at, this is a study looking at all the things I told you above in patients who are post-transfusion, because clearly they got something from their transfusion that led them to be sick. The microbiome and B and T cell gene rearrangement, we're trying to predict the patients who will develop lymphoma, so that perhaps early intervention could be utilized. And here's the collaborative institutes that I'm working with right now, NOVA, Center for Infection and Immunity, Griffith, OMI, work well, and recently UBC. And I think this collaborative effort is really what it will take to solve this disease at some point in the future. So I have just a few conclusions with respect to these two statements that have come out in 2015. And that is the impact of P2P and IOM and the name change has clearly focused attention on the seriousness of this disorder. And it really leads us to fertile ground for a call of action. If I were the patients, I would say, look at these two prestigious places that said we need this and we need this and we need this. Give it to us. There's never been a riper time to go after these people. The recommendations are out there, but they'll just sit there if there's no call to action. The IOM establishes strategies to disseminate the information. I hope they do this. They budgeted a large amount of money to go to schools, high schools, middle schools, colleges, medical schools, etc., and disseminate their primer and their definition. NIH has been encouraged to set up a network of centers well-funded rather than underfunded and to collaborate internationally. These centers should really work on diagnostic and prognostic markers, endpoint determination, which is just critical, and cost-effective therapies. It is true that most of the studies done to date have been done in small numbers. They've been relatively poorly conducted studies, and that's been a big problem. But I think the last one is really the thought that needs to be paid attention to. Many, many research needs are present, but little funding results in little research. And little research results in no evidence, and no evidence leads to no future funding. So it's really a very vicious cycle, and without evidence, you're never going to have a treatment because Big Pharma needs to have the evidence. Now, on the positive note, these reports should be leveraged, not killed. And I strongly believe that. The CDC has removed their toolkit, waiting to revise it. But reorganization is required. I think this really should be international. We need sufficient research funding, collaborative networks, centers of excellence, RFAs, validated outcome measures, and physician education. And then we'll continue forward progress. But in balance, you can see, as the lovely introduction told us, there are changes. There are things being done. There is good research being done. And, we just have to make a call for action, leverage these things, and support your local efforts is what I can really tell all of you. So thank you very much for the opportunity to speak. And
Thank you, Dr. Peterson, so much. Please don't go anywhere. We have about 20 minutes on the clock, so we're open to take questions. Elizabeth has a microphone that she's going to move about the audience with. So here he is. If you, is it going to work? Maybe I'll start. One of the things as a patient advocacy group that we recognize and is sometimes difficult for us to even communicate around is just how different people can be with this disease and the range of severities that we see. Everything from, there are so many people who aren't with us here today who we know and love who can't be here because they're at home, they're in bed. There are people who have struggled to be here. There are people like me who's standing up here in front of you. So that's a pretty broad range of patients who've been diagnosed with this condition. So what can you tell us about what's happening around subgrouping and recognition of how this disease really can present quite differently amongst patients?
I think we've been working with an artificial construct for many, many years. And that's why you see different presentations, common symptoms, but they're, as you see, the common symptoms really are very common to chronic immune diseases in general. So subsetting is absolutely critical, but to get appropriate subsets, you need a large number of patients, and that's what, to do GWAS effectively, gene sequencing, you need 15,000 patients. And nobody at this point in time has 15,000 patients in their database. Pooled, we start to get to those numbers, but not individually. With respect to severity, that's a very interesting question, and I suspect we'll have answers in the cytokine profiles and things like that. I am still concerned, as I pointed out and I emphasized, how we reach the most severely affected, because I would love to study them, but it's nigh unto impossible. So.
Thank you. I'm going to let Elizabeth run around.
I know this is going to be on talk, but and that is, in clinical practice, what have you seen that helps with post-exertional malaise?
Oh, that's a very interesting question. Energy conservation and core strengthening. Oh, for recovering. Staci, I think you can better address that, and you'll hear about that. But I do prescribe for everybody energy conservation, core strengthening, anaerobic exercise, which can improve you 10 to 15%.
I'm sorry, I didn't hear you.
For post-exertional malaise, the best thing is to avoid the exertion that caused the malaise.
Thank you for your work, Dr. Peterson. Very much appreciated and recognized the location population. Is this disease appropriate for GPs to solely care for managing the patient, clearly understanding the disease, and then providing meaningful competent care? Thank you.
I was expecting that question because I'll repeat it. Essentially, the question is this disease within the realm of a primary care physician to diagnose, treat, manage, etc.? And I think the answer to that is no. I think the primary care physician should be able to diagnose and should be able to triage just like they do in many other diseases. But as far as management goes, it's extraordinarily complex. It's very time-consuming. You know, the average American physician spends under 7 minutes per encounter. I can't barely get 2 symptoms out of you patients in 7 minutes. So it would be very, very difficult. And I don't think it's we aren't sophisticated enough yet to make valid algorithms. You know, there are valid algorithms that are used everywhere for every disease now. Diabetes, if the blood sugar is this, then do this. If the, et cetera. Congestive heart failure, if the weight goes up, do this. But there's no such algorithm that's validated in chronic fatigue ME. So I think at the moment, a better strategy would be develop the centers of excellence where the patients could go to, and they could be properly diagnosed and a course of therapy instituted. That's my personal opinion.
Hi. I just wanted a couple of definitions that I didn't understand. NK dysfunction, and you used the term cytokines quite a bit, and I don't quite understand either of those are.
Fair questions. Natural killer cells are a limb of your immune system. You're all probably familiar with B cells and T cells. And natural killer cells are primitive cells that, for example, sharks only have natural killer cells. And their primary function is to scavenge neoplasm cancer cells and scavenge for viruses. So you can see when they're suppressed and not operating properly that you may have significant problems, at least of surveillance. Cytokines are immune modulators. They're very small, rapid-acting chemical signaling between the immune system. And we have cytokines everywhere. We have them in the peripheral blood. We have them in organs. We have them in the brain. And there was... Every day they discover some new ones. So it's a very interesting part. The multiplexes that you're seeing that are being used in all these studies, on one plate do 51 different cytokines. So we can do a lot of research. And there's a big interest in cytokine blockers. You know, they're being used in rheumatoid arthritis and systemic lupus and a lot of disorders.
Is it measurable through blood tests?
It is,
Both those things?
yes.
Thank you.
I would like to ask you if you know any center, any clinic, any hospital in the world where a parent can take a young adult who has had it for a number of years, and beyond clinical tests, beyond the few experts that we have, you can actually take somebody. You can take a person who has cancer to a cancer institute, and you can take a person with cardio to a heart and stroke institute. Is there anything in the world, anywhere in the world, any hospital, anything available for any patient?
Yes and no. Nova Southwestern University, for example, does a lot of research and also sees patients clinically and follows up. There's the translational piece that I mentioned to you is very difficult to accomplish. So as far as I know, there's not a large center that just does diagnosis and treatment. Most of them are also involved in research. So it's a model that I think has to be there, a center of excellence. I think, a follow-up of your question about should primary care physicians be treating this disease, I think that it's very suitable for a center of excellence to do diagnostic markers, recommend interventions, and then refer the patient back to the primary care physician for sort of routine follow-up, which is what I do with my patients.
I got confused. I'm a huge fan, so glad you're here. On the MECFS alert videos that you did, you said that you were having some great success with patients, like some people coming to, let's say, 70% of their pre-onset functionality.
Yes.
And my understanding is a lot of that is antivirals, immune boosters, and some are on Ampligen. Can you tell us sort of what range of recoveries you see with your patients and what seems to be working best?
Yeah, I still think after all these years, 28 years and counting, that Ampligen is the single most effective drug as an immune modulating drug. It has had difficulties with licensing, as everybody knows, but it's the only drug that I've utilized where I can actually get people back to full-time employment or full-time skiing or full-time mountain climbing or something, Ampligen, which is available to you in Canada, which is so bizarre.
And then what percent of your patients recover, approximately what percent recover, to what extent?
70% have about an 80% recovery.
70% of your patients?
They do. That are selected for their markers.
Okay, out of the people who take the app.
Right.
And just out of the general population?
It's not available for the general population, so we don't have that information.
Okay. And but within your practice, not just Ampligen, but anything, like what percent?
Well, I'll answer it a little bit differently, but I think it gets to what you're asking. 15% of my patients, 1 out of 7, meet the entrance criteria for Ampligen. And of those, 70% have a dramatic response.
Okay, and then the ones who don't respond to Ampligen, what recovery levels do you get?
Well, some people have minor spontaneous recovery, but I agree with the general statement that it's a rare patient that has a spontaneous recovery, certainly to the point. You know what I think it is? I think people adjust to their illness like they do to any chronic illness. So they actually sometimes quit complaining. You know, I sometimes see people back. No, really, I sometimes see people back and I say, well, I haven't seen you for a year. Are you all well? And, well, no, you've heard everything. You know, it's all the same. So I think you have to factor that in. But the ones who get well will certainly tell you. And they give back their disability. I just love that when that happens. Yeah. So.
Thank you.
Yeah, I skipped over that, but about intensity and severity of symptoms, are those included in any of the diagnostic criteria? And the answer is absolutely yes. I skipped over that for simplicity today, but the document does have scales for every single one of those symptoms that you can incorporate or your physician can. It's a great question. It really is, and one that just intrigues me, because it was just recently that I found out that something like 95% of drug development is driven by the market, not by the disease or the need. So the drug companies look for something that will sell, that will make them a whole bunch of money. So I'll give you the example of hepatitis C drugs, which are great because we can cure hepatitis C now for $1,200 a tablet. A tablet. Or $150,000 a year. And that was driven because if you look at it, the drug companies said, wow, there's a market, we know how to diagnose it. Person goes, gets a hepatitis C test, we can cure them now, and we're going to charge what we want to. And so it's a perfect model for them. And Big Pharma looks for that. We have invited Big Pharma, and they just look the other way. They say, you don't have a marker, you don't have an outcome, how are we going to do a study? We don't even know what the market is. For example, if they came out with an effective therapy that was $150,000 a year, would all of you in the room sign up for that? You know? So, Big Pharma, the point I made I'm going to make again, because if you had one licensed drug, that one company started making money, you'd have everybody else jumping on the ship. You know, and the example I give you is AZT for HIV. It was our first licensed drug for HIV. It had not been thoroughly tested. The dose studies had not been done. Fairly toxic drug, and yet it was licensed because there was demand. And then, you know, now we have 29 or 39 or some huge amount of very effective drugs, and all based on a business model and patient demand. Now, the FDA, interestingly, when I was at a hearing last year about this, said, well, where are the patients? Why aren't they here? And I had to ask, too. There were like 300 doctors and 100 pharmaceutical companies and a handful of patients. So they did not see the demand. You know? So that's a difficult problem. But, you know, don't underestimate what an individual can do sometimes. There's one gentleman who has a very rare disease, and he got the NIH to study him to the tune of like $50 million. And they identified his gene defect. One patient. So, you know, we're kind of looking for our model patient who has that kind of influence over NIH or the FDA or any of the agencies. Because I think, I would guess, in a country like Canada, you just follow the lead of somebody else. Probably. Of the UK says do this, or the IOM says do this, or the P2P says do this. But that's probably starting to change. There's certainly some really good work being done here locally. So, yes?
I have a question. Back to antigen, those numbers are so stunning. So the 1 in 7 patients are eligible for it.
Yes.
How do you know what kind of testing do you do?
We do Toll-3 receptor testing and NK cell function cytokine analysis.
And is that done, can that be done anywhere?
Could be done anywhere.
Could you repeat the test, please, a little bit slower, please?
Natural killer cell function, Toll-3 receptors, which is how the drug acts, cytokine panel.
You can barely get a CBC
The technology is available.
That's different.
No, I know that, but it's...
I have a pretty loud voice, so I just wonder, does antigen help people in the more chronic stages of chronic disease?
Oh, I prefer to have the people who've been sick less than 3 years. But I have tried some people who've been sick for 20 or 30 years, and as you might predict, the response is slower and it takes longer, but there have been some very dramatic responses.
In the more chronic?
Yeah, I just treated a person, kind of a famous person in this field, who very reluctantly finally borrowed the money to get on Ampligen. And I said, just hang in there because you've been sick for a long time. And she's in year 2 now, and she said, thank you for encouraging me because I'm the best I felt in 22 years. So, yeah.
I have a question over here. Sorry, got a question here.
Yeah, I'm just wondering, if Ampligen is so effective, why is the company having such a hard time getting it on the market? And if I were a drug company and I saw that this small company had this drug, it just needed a little boost to get it over the hill, why aren't drug companies clamoring to buy this company to move it to the final phase if it's actually so effective?
Because it's off patent.
Because what does that say? It's not off patent.
So just to say we're at 2:15, so we're running out of time. I guess we'll have our last 2 questions, and then there'll be questions at the end.
Dr. Peterson, this question is related to everything we've just been talking about, and people ask, can this testing be done here, anywhere? And you say yes. Dr. Hyams, I know Mr. shook his head no. And I know Dr. Hyams, and I'm just curious if you don't mind, what do you say about Dr. Hyams here locally?
I think we would love to do it. I think there's a huge need for these tests, but unfortunately we've got to show enough evidence that is going to be meaningful in the diagnosis and also in the treatment that is going to be offered, because I think almost doing a test when there's no treatment to sort of follow through is probably not in the best interest of the patient. So I used antigen. I was talking to Dr. Peterson, a few case studies in England, and had a similar response. When I was with Dr. Cheney, we saw a very ill but young attorney from New York get well and go back into practice. I did experience some patients who got a lot worse. So I think there's the other side of the coin that one must remember, that it's quite a tough drug, giving intravenously twice a week, and some patients get a lot worse with that, depending on your severity and chemical sensitivities. But as Dr. Peterson said, the technology is here to do those tests. We just have to find enough evidence to make it because they're very expensive, of course.
That's what I meant by that. You certainly have the technology to do it. I understand that a primary care physician can't even order those things, but and perhaps they shouldn't be. The paradox I was pointing out is Ampligen is a licensed drug in Canada. So if you had a treating physician, you can buy the drug, where I can't. But I have a number of patients who come down for 3 or 4 days and get all their blood drawn. And then they bring that back to, but I don't think anybody's using Ampligen on the West Coast, but they are in the East. And so there are more ways to skin the cat sometimes if you think out of the box, so to speak.
We have one last short question here.
How long do your average patients stay on Ampligen?
Oh, great question, because we can show chemical improvement in NK cell function and cytokine profiles at 6 months. And then by 1 year, they're really doing far, far better if they're going to respond. And the current protocol allows them to be treated up to 2 years. And now in the newest protocol, you can take drug holidays and then resume the drug if you have a relapse, which is very, very, very beneficial. I have some patients, it's a compassionate care protocol, so that have been on and off the drug for 10 or 12 years and maintain their functional ability. Thank you all.
Dr. Peterson, thank you. Thank you so much. We will have some time, hopefully at the end of the afternoon, if there are any more questions.